Good morning, everyone. I would like to thank the invitation to participate in the international meeting Free Pancreas Webinar with the theme Endoscopic Management of Acute Pancreatitis. The author declares that he has no conflict of interest. To address this hot topic issue, we will analyze some key points such as the role of EUS and the indication of early ERCP plus endoscopic sphincterotomy and the treatment of acute pancreatitis, the natural history and classification, indications and techniques for treatment, outcomes, the use of plastic versus lumen opposing metallic stent in pancreatic fluid collection are discussed. During the episode of acute pancreatitis, the discussion about the cause and severity are relevant. Where there are doubts about the biliary etiology, EUS should be indicated. Regarding the severity, EUS is not used because the clinical and radiological scores are much better than EUS findings. In patients with suspected choledocholitis, EUS imaging has a sensitivity of 94%. And these results show that the EUS is better than MRCP and abdominal ultrasound for the diagnosis of microlithiasis. This video shows a microcholedocholitis in a patient with a clinical suspected CBD stones, but CT and MRCP were negative to identify their presence. In patients with recurrent acute pancreatitis, the EUS is indicated because this procedure should exclude biliopancreatic junction anomalies, identify pancreatic cystic lesion like a cause of acute pancreatitis episode, and identify the mass causes of main pancreatic duct obstruction, and rule out the autoimmune pancreatitis. This video shows one case that EUS confirmed the BD IPMN in the UCNAT process with vegetation, not seen in the MRI inside the cyst like a cause of acute pancreatitis. The acute biliary pancreatitis occurs due to migration of stones through the duodenal papilla, like this video in a patient with an episode of acute pancreatitis. How should we treat biliary obstruction after the diagnosis of acute biliary pancreatitis? Remember that at the time of admission, most of the stones have already passed through the duodenal papilla. At this point, the discussion is about what is the best treatment method and how to select the patients. This video shows a patient with acute biliary pancreatitis undergoing to ERCP 48 hours after the onset episode. And we find the impacted stone on the papilla being successfully removed. At this time, with a needle knife, we can remove the stone impacted in the papilla. And after this procedure, we can make the endoscopic sphincterotomy to access the biliary tract and remove all stones inside them. Authors propose early treatment up to 48 hours for proved acute biliary pancreatitis. However, does this form of treatment reduce the occurrence of adverse events or mortality? Surgical treatment has a poor results, and ERCP, more endoscopic sphincterotomy, has been proposed because it is less invasive than surgery. But is there any difference between it being done before 48 or 72 hours or after that period? From 1988, an English randomized control trial and 121 patients with acute biliary pancreatitis without cholangitis were divided into two groups. One submitted to ERCP plus endoscopic sphincterotomy until 72 hours after the onset episode, and the other submitted to conservative treatment. The authors conclude that ERCP plus endoscopic sphincterotomy is beneficial in patients with severe acute biliary pancreatitis, and that it had no advantage in patients with a mild episode of acute pancreatitis. This multicentric randomized control trial in 103 patients with acute biliary pancreatitis without cholangitis revealed that early ERCP plus endoscopic sphincterotomy don't reduce systemic and local inflammation in acute pancreatitis. If acute cholangitis can be excluded, early ERCP plus endoscopic sphincterotomy is not mandatory and should not be considered. This randomized control trial from Dutch pancreatitis study group showed that in patients with predicted severe acute biliary pancreatitis without cholangitis, urgent ERCP plus endoscopic sphincterotomy didn't reduce the major complications or mortality compared with conservative strategy. The ERCP should be indicated only in patients with cholangitis or persistent cholestasis. That's why the radiological classification of pancreatic fluid collection is essential. This table shows the 4 types of pancreatic fluid collection must be recognized by TC imaging. The first 2 should be treated conservatively when the patient's situation allows. The last 2 should be treated more aggressively if these patients present symptoms that justify the drainage or debridement. For this reason, the proper classification of the pancreatic fluid collection is essential to determine the type of treatment, as it will vary according to this classification. To obtain the best results, the detailed analysis of the TC imaging shows, for example, an acute pancreatic necrosis require conservative treatment, or a symptomatic unilocular pancreatic pseudocyst require drainage, or a patient with compartmental syndrome due to a Wolodoff necrosis require urgent endoscopic debridement. Another important point is the density of the cystic fluid, which can be classified by the AUS as low, observed in patients with pancreatic pseudocysts, where in this situation can be accomplished by a placement of plastic stents and only one orifice that's enough to treat this patient. Or if the fluid is higher and dense, and hence, as in this image obtained by the AUS, the drainage must be more aggressive, requiring the opening of a wide fistula or the manufacture of multiple holes for an effective drainage. Regarding the time of the intervention, they must remember that after analyzing the natural history of pancreatic fluid collections, a minority of them will need to be treated in. In addition, the later the treatment is performed, the better result will be as observed in this slide. Patients with symptoms and or complications, biliary or GI obstruction, refractory pain, and vascular compressions with a well-defined wall, larger than 6 centimeters, and with more than 4 weeks of evolution should be treated with the endoscope procedure. We must keep in mind that for the treatment of pancreatic fluid collection, we must differentiate between drainage and necrosectomy. Drainage is a quick procedure and includes the creation of a fistula with the implantation of a stent that can be plastic and or metallic stent. Necrosectomy is more aggressively with the creation and dilation of a fistula for the exploration of the cavity with the removal of a necrotic tissue or debris, being performed in several sections. Let's remember that the drainage for a wallet of necrosis will be unsuccessful in 30% of the case with an infectious evolution. The treatment of pancreatic fluid collection can be surgical or percutaneous. This study published by the Dutch group comparing open surgery versus percutaneous step-up approach showed that the preferred treatment for patients with necrotizing acute pancreatitis from a clinical and economic point of view in this percutaneous procedure and, if necessary, minimally invasive necrosectomy retroperitoneal as an adjunct to comprehensive treatment. This slide shows that endoscopic treatment can be proposed for pancreatic fluid collections, and nothing is more obvious than comparing the minimally invasive surgical step-up approach versus minimally invasive endoscopic step-up approach. This study highlighted that endoscopic treatment is preferable. Another important point is the use of ERCP for transpapillary drainage of pancreatic fluid collections. I remind that this technique is inadequate for drainage of cysts with large volume or when there is no communication with the main pancreatic duct, and that the pancreatic fluid collection located in the tail of the pancreas, adequate drainage is practically impossible. Therefore, it is necessary before treatment and can be used in selected patients with relaxed pancreatic fluid collection. Nothing fairer than comparing AUS guide drainage or necrosectomy with standard transmural endoscopic drainage. However, conducting a randomized controlled trial with these prospective techniques is difficult to perform. The recommendation of the 3 most important gastrointestinal endoscopy societies is to use AUS guide transmural drainage in patients with a non-bulging collection to avoid intervening vessels and not requiring fluoroscopic control. Regarding the type of stents, we have the double pigtail plastic stents, metallic biliary stents, and lumen opposing metallic stents. This table shows the advantages and disadvantages of each one. Double pigtail does not migrate, for example, but several plastic stents are needed to maintain the fistula, whereas a biliary metallic stent has a larger diameter, but can migrate, and LAMS, for example, does not migrate. It is easy to implant, but is expensive and has the risk of occlusion or bleeding if remaining for a long time in the patient. These two recently published meta-analyses show that LAMPs have better clinical adverse outcomes and low adverse events compared to plastic stents. Therefore, LAMPs is indicated in the majority patients with pancreatic fluid collections. In this study, designed in two different periods, compare the results of plastic stents versus lumen-opposing metallic stents, showed the clinical success rate was better for LAMPs that use LAMPs associated with the plastic stents, increase the clinical success rate when compared only to the use of plastic stents. This video shows the AUS guided necrosectomy technique after insertion of LAMPs, following by fluoroscopy. After the implantation of LAMPs, we performed the dilation of the LAMPs. And after this was possible to move on inside of the pancreatic fluid collection and remove the necrotizing tissue. At this moment, we pass through the prosthesis the balloon dilation, and after it's possible to, inside the cyst, remove the debris. Our surgeon colleagues insist on performing the surgical debridement of necrotizing acute pancreatitis by laparoscopic or open pancreatocystogastrostomy. The concept was to create a 7-centimeter fistula to remove all necrosis at once. And this study not show difference between surgical and endoscopic treatment, as we can deduce. It is an old technique with a new makeup, but we need to wait to compare the results to obtain more robust conclusions about the comparative study like these two techniques. In conclusion, acute biliary pancreatitis, the early ERCP, plus endoscopic sphincterotomy only in patients with cholangitis, persistent cholestasis, or common bile duct stones detected by AUS and MRCP. The differential diagnosis between pancreatic pseudocyst and Wallenhoff necrosis is important and essential because the therapeutic approach is quite different. For both pancreatic fluid collections, endoscopic therapy is the best treatment choice, and the use of AUS is preferred, and the use of LAMPs is better than plastic stent. And the ERCP before treatment is unnecessary. MRCP 3T is an effective substitute with advantage, and a transpapillary treatment becomes effective only in selected patients. Thank you for your attention.